student joining us. My name is Sunny Jaiswal. I am AGM Marketing from Ajanta Pharma. And indeed, it's a great pleasure to welcome all of you for a Cardio Master workshop for the DM and DNB student. This is our fifth edition, and indeed, this is going to be the fifth workshop for all of us. Now, before we begin our today's session, I would like to take a minute to take all of you through Ajanta corporate presentation. So, good evening once again to all of you. Today, Ajanta Pharma is truly specialized on pharmaceutical company. We call ourselves as an Indian multinational company having operation over 30 plus countries, offering 500 plus products, wherein 7,900 plus Ajantites working over 30 nationality with one promise of good health for all. Today, Ajanta Pharma is present in the rest of Asia, Africa, USA, besides India. What truly differentiates Ajanta Pharma today is its advanced research and development center situated in Mumbai, over 1 lakh square feet in the heart of city of Mumbai, wherein 850 plus scientists are relentlessly working. And very happy to announce that today Ajanta Pharma, over 7% of its revenue is spent on research and development. With its strong R&D capabilities, what you are able to see on the screen, we could able to offer several different dosage forms like tablet, capsule, ointment, sterile eye drop, injectables, and oral jelly as such. Today, Ajanta Pharma proud to announce its rich differentiated basket over 150 plus first to market products, truly first time in India products, and some of the products like entire Metexcel franchise, entire Bisoprolol Besicor franchise, and even Ajanta Pharma is pioneer in statin combination with brand like Atorfit CV, Rosofit CV, and Rosutor Gold. And many of you would be familiar and instrumental behind making this brand what are there today. Beside it, doctor, today Ajanta Pharma has a 7 manufacturing facilities at Pithampur, Dahej, Guwahati, and 4 at Aurangabad. Out of the 4, 2 are the USFDA approved plants situated at Patan and Dahej, Gujarat. Very happy to announce that again Ajanta Pharma today belongs to only those 4% companies in the world who has received 0% observation from USFDA as such. Today, Ajanta Pharma's India business has a select presence in some of the segment like cardiology, ophthalmology, dermatology, pain management, and very recently we have ventured out into nephrology and gynecology segment also. To all those who are interested in stock market, possibly will be very happy to know that today Ajanta Pharma could able to give 36,000 plus percent of return to all its investor over 16 years as such. Not only this, doctor, today, Ajanta Pharma is actively involved in CSR activities like diagnostic eye camps, upgrading educational facilities, cataract operation, family planning program, and on the right side of my screen, there are some numbers pertaining to CSR activities, are testimony of our commitment to CSR as such. Not only that, doctor, today Ajanta Pharma is committed to preserve the environment by adopting environment-friendly processes. It offers zero effluent discharge, recycling of water, and our aim is to run our plant on at least 50% of energy coming from the solar plant, thereby would like to promote the green across all the manufacturing location. And all awards and recognition are not possible without help and support, doctor. And very happy to announce that very recently in year 2016 we could able to get the time young makers of the award by our MD and GMD by honorable Prime Minister Mr. Narendra Modi. And some of the accolades what you are able to see on the screen are again testimony of the support and guidance of all the doctors and customers, and we are actually grateful to all of you for this particular award. Not only this, today Ajanta Pharma is pioneer in conducting CPR workshop across the country, wherein 2,400 plus workshop being conducted, wherein 66,000 plus people were trained in CPR, and this feat was registered twice in Asia Book of Record and World Book of Record also. So with this, I'm ending the corporate presentation. This is our latest topic. If you happen to pass to Mumbai, we request you to kindly visit us. We'll be very happy to take all of you through our latest office. Coming back to our core agenda for the evening, doctors, we welcome you back for this Ajanta Pharma DMPG program, wherein our course director, Dr. Ajay Mahajan, sir, and under his able leadership, this program is running now, and we are entering into the 5th edition. And of course, we have guidance of Dr. Dhiraj Kumar, sir, from KM Mumbai. Today, we are very, very happy to have a very senior faculty known as who's and who's in cardiology, starting from Professor Dr. C.V. Minasar, HOD of SMS Jaipur, Professor Dr. Sanjay Tagesar, consultant, senior consultant cardiologist from Apollo Delhi Hospital. We have Dr. Nitin Gurkule, sir, consultant cardiology and head of the department of echocardiography at Jupiter Hospital, Thane. And yes, of course, Dr. Ranjan Kumar, sir, ex-head and professor of NRS Medical College from Kolkata. We welcome all the senior faculty members to our today's program as such. So the today's case is going to be on the aorta arteritis. A case will be presented by the DMPG student of SMS Medical College, Jaipur. There is also expert lecture topic from imaging on cardiomyopathy by Dr. Nitin Gurkule, sir. So now we have the two case speaker from SMS Medical, Dr. Ayushi Jain and Dr. Hitesh. We welcome both of you. Now, for without further delay, I would like to hand over the session back to our esteemed moderator for the winning, who is none other than Dr. Ajay Mahajan, sir, and Dr. Dheeraj Kumar, sir. Over to you, sir.
Thank you, Dr. Sani, for that wonderful introduction. Now, without any further ado, I would like to pay homage to Dr. Ajay Mahajan, sir, for having conceptualized this EMPG Cardiomasters workshop so that we give a platform to students in order to develop their confidence and also help improve core concepts in cardiology. And of course, we are enthralled to have four wonderful examiners today. And to start it, I would like to request Dr. Nitin Murkule, sir, to take his lecture on imaging in cardiomyopathy, a topic which is a very important topic for all of us, whoever is preparing for an exam, as well as whoever is practicing in the real world in order to approach patients of cardiomyopathy. Dr. Nitin, sir, over to you.
Thank you, Dr. Dheeraj. Can you tell me how much time do you have for the lecture?
Sir, approximately 20 to 25 minutes, sir. But
Fine,
if you
fine.
really want, you can
No,
go
no,
beyond that
I
also.
will stick to the time. You can always
Yes.
stop me because I am going to do a case-based presentation. So you can
Yes.
stop me at any moment because otherwise there are too many cases there. So I will just share my screen. Okay, so we will start with this imaging in cardiomyopathy session by just going through a lot of cases and looking at the nuances of imaging for the diagnostic and prognostic and therapeutic purpose. As we know, the fundamental tenet in the cardiomyopathy is that you should get the etiology. Okay, just by giving a morphological diagnosis or the morphological functional phenotype is not the end. Like just saying dilated cardiomyopathy or restrictive, we have to reach the etiology, and for which the imaging is useful. So you have to have the final diagnosis where you have the etiology and a phenotype. So the the cardiomyopathy phenotypes are both morphological and functional. So in morphological, we have got the hypertrophy or dilatation, or you may not have a hypertrophy or dilatation, but you will have certain myocardial alteration. So that also you have to pick it up as a cardiomyopathy. And then obviously you have got functional, that could be systolic dysfunction or diastolic dysfunction as you would get in the restrictive cardiomyopathy. As we know, the recent ESC guidelines have proposed five morphological phenotypes of the cardiomyopathies: hypertrophic, dilated, ARVC, restrictive, and non-dilated LV cardiomyopathy. So one thing is sure that the so-called non-compaction LV cardiomyopathy is now thrown out of the window because it is no more a separate phenotype. But we have this new phenotype called as non-dilated left ventricular cardiomyopathy, and we will see in certain cases of it. And this is just the cartoon for all these five different phenotypes. What is the prevalence? And as we know, the HCM is the most prevalent one, and we do not know the incidence of NDLVC. Okay, but the least one is obviously the restrictive cardiomyopathies. So how do we go about it? So we have to reach this phenotype best integrated etiological diagnosis. So first we would go through the clinical scenarios. Most of the time patient presents with certain insignificant symptoms which can be confused with so many other pathologies, especially the coronary pathologies. Or there could be incidental finding of an abnormal ECG murmur or an arrhythmia, or you may be evaluating the patient as a part of family screening. Then you should have a very detailed echo and, if required, MRI to have a morphological and functional phenotype characterization. Then you have to take use of the clinical examination, then looking at the ECG carefully with a cardiomyopathy mindset. Not every STT changes or the blocks to be interpreted as a coronary disease, but with a cardiomyopathy lens, you should be looking at the ECG. Then do a good pedigree chart, do a genetic testing in certain cases, and also you should look at certain laboratory markers, and if at all there any extra cardiac involvement, those can be evaluated. So we will start with the cases now. So here's a 28-year-old man, absolutely asymptomatic, but a diabetic on oral hypoglycemic agents, detected to have a slow heart rate. ECG showed CHB. There is no family history of cardiomyopathy. This is his ECG, and you can see that the P waves are walking through, and there is a complete heart block, but the escape rhythm is narrow QRS and with normal axis. This is his echo, and we can see that there is no hypertrophy or dilatation. The systolic function looks normal, except that obviously there is a bradycardia, and the valves are normal, and there is no regional wall motion abnormality in any of these short and long axis views. And you have this diastolic mitral regurgitation, as you can see here. Okay, obviously that is related to the complete heart block. You have normal E primes in this patient and normal aorta flow. And the left atrium is not dilated. Why it is important? Because that means this is not a congenital CHB, because otherwise by this time the atrias would have been quite dilated because of the high output sync. So this is an acquired CHB. The global longitudinal strain is normal, and we'll look at his MRI. The MRI will also is also showing that there is a normal LV contractility, no regional wall. The long axis is also normal. The atrias are not dilated, telling you that this is not a long-standing or congenital heart block. The global longitudinal strain on the MRI is also normal. So it does with the feature tracking, the way you do speckle tracking in the echo. And then if we go ahead, we look at the parametric cardiac MRI. This is called as the T1 map. Okay, you don't have to get bogged down by these terminologies. This is a very simple thing. T1, T2, T2 star are different magnetic properties of the tissue. And what you do here is that for every pixel in this particular slice of the heart, the basal, mid, and the apical, you find the T1 values of every pixel, and then you have this color spread here from 0 to 2000 milliseconds, and depending upon the value you give a color there. So this is a parametric imaging. So you can see that generally what would you do is you will keep the myocardial T1 values at somewhere in the center, but you can see that this is all the way going down in this color spectrum towards the absolutely bluish shade, telling you that these T1 values are absolutely low. Okay, so and so also you can see there are areas where the T1 values are extremely low. So why the T1 values have gone down in this myocardium? As you can see that the this particular scanner has a normal T1 value for myocardium at 1050, and here it is 700. So it's absolutely low. So that means your muscle is having some paramagnetic substance, and obviously you must have realized that he is a young diabetic. So it's very likely this is a hemochromatosis. So this is the familial hemochromatosis. He is not a one who has got any blood transfusions like the Thal measures. So you can see the just looking at this parametric map, you already have a diagnosis in hand. And these are called the T2 maps. The T2 maps are generally done for the edema, but here also the T2 values are absolutely low, telling you that this is there is a iron in the myocardium. And if we look at there is another magnetic property called as T2 star, which is a very specific for the iron. And this particular imaging is especially done for the children, thal major, who take recurrent blood transfusions, where you look for these T2 star values for both the myocardium and for the liver to pick up the iron deposition and start them on chelation. So this is one of the very important use of cardiac imaging, which has helped almost millions of children. Now this is just a cross-sectional area in the upper abdomen, and you can see that the liver is absolutely jet black. And this is all because of the iron deposition. You can see the difference compared with the spleen here. So this is basically has got a systemic iron deposition, and this is a familiar hemochromatosis. Now, luckily, there is no late gadolinium enhancement here. That means he has not developed any replacement fibrosis. So that means you have a cardiomyopathy where there is no dilatation, no hypertrophy, but you have myocardial alteration because of the low T1 value telling you that there is an infiltration. You can look at these ferritin levels, which are 7,600, and you can see he has a bronze color skin. And so we go ahead with the genotyping, and he has a hemojuvelin gene, pathological gene. Now, this particular hemojuvelin is more common among the familial hemochromatosis in the Southeast Asian or non-European countries. This gene actually influences the hepcidin, which is a very important part of the iron homeostasis. And this particular pathological genotype leads to iron deposition in everywhere in the liver, in the heart, in the pancreas, in the gonads, and they can have hypogonadism and diabetes and also cardiac failure. So if we put it as per the ESC guidelines, the clinical scenario, as you know, was a heart block. The morphofunctional thing is only myocardial low T1 value. So he's a non-dilated LV cardiomyopathy. ECG is a CHP, and he has got very high phenytoin levels, and you have got a hemojuvel NDLVC with familial hemochromatosis. So that's a true phenotypical and etiological diagnosis. Okay. Now we'll go for second case. We'll just touch upon different phenotypes. 22-year-old boy. He had a chest pain and uneasiness and vomiting while he was playing cricket. And though that was a time of just, I think, the COVID, was admitted in a peripheral nursing home with an ST elevation MI. He had received his COVID vaccination second dose 2 weeks before. There was no fever or any viral prodrome or body ache. He was thrombolized looking at the ST elevation, and thereafter he was transferred for an angio, which was normal. So this was his ECG. We can carefully see that there are good ST elevations in the inferior and the lateral lids. And and after thrombolysis, the STs have come down actually. And you can see there is a loss of R wave height and a deep Q wave now in the 2-3 AVF V4 to V6. So he was subjected to coronary angiography, and it shows an RCA with an RV branch and a PDA, and he has got this circumflex which is looks codominant, and there is a LED normal. So he was labeled as probably a recanalized circumflex artery. Okay. And then these are the other images, but let us start looking at his echo. The first thing that you will realize is that the RVOT is hardly contracting. Very unlikely in a circumflex territory, circumflex coronary thrombosis, you will have an RV involvement. Okay. And as we look at the other echo find, you can see there is a significant RV dysfunction and hardly any cooptation of the tricuspid leaflets. You also have an apical akinesia. You have a septum which is in diastole going towards the LV, showing RVDP is very high. And you are almost, there is absolutely no contractility of the RV and a severely depressed LV function. You go to the apex is also akinetic, LV is very poor. Very, very unlikely that this has anything to do with a coronary disease in this patient. There's a mild MR and there is a hardly any E primes, and the GLS shows a very variegated appearance with some areas which are actually showing systolic expansion. And RV close-up view shows you a very severe RV dysfunction, and the RVOT is absolutely akinetic. So here is the IVC which is congested. So let us look at his MRI, and the MRI, as you can see, is showing you the same thing. The RV contractility is absolutely poor, and there is a severe global hypokinesia, and almost the apex is akinetic. And we have this EF which is 22% here, and the RV ejection fraction is just 16%. If you look at this stack of long axes, you can see the same thing, poor RV functions and the multiple areas of akinesia which cannot be restricted to any coronary territories. And we'll look at the late gadolinium enhancement, and it was reported as circumflex territory infarct. But if we look very, very carefully, you can see that though the LG lead gadolinium enhancement is transmural here, it is actually it's not starting from subendocardium, it is starting from subepicardium and then becomes transmural. You can clearly see it starts epicardially and then becomes transmural. That means the injury started epicardially and not subendocardially, and that also tells you that why he had an ST elevation, because of the epicardial injury that he had in the inferolateral wall. The more images, and you can see here that in the anterior wall also you have got transmurality here, but then just close to it, it is epicardial. So this cannot be an ischemic infarct. This has to be a part of a myocarditis or myocardial inflammation, which has caused this kind of ST elevation and poor elevation. You can see the apex which is transmurally infarcted, but you can see on the septum it is on the RV surface that you are having the fibrosis. This particular pattern cannot happen in an LAD territory infarct. Otherwise, it has to, the wavefront of necrosis has to start subendocardially and then go to the transmurally. So definitely, this is a process which has started epicardially and then became transmural. Post-COVID myocarditis is very well known. The literature shows that actually the median age was 24. Our patient is 22-year-old. Generally, they are male. The most of the myocarditis has been reported with mRNA vaccination, though we did not have mRNA-based vaccines, and generally after second dose, and generally with a severe chest pain. And most of them are very, very benign. They settle just with anti-inflammatory drugs. But why this patient developed such a massive necrosis and landed up with a dilated cardiomyopathy with so much of fibrosis? So this brings to this concept of a double hit. That means what happens is that you already have either a dilated cardiomyopathy gene or an arrhythmogenic cardiomyopathy gene, and you get an environmental stressor, which could be viral, autoimmune, exercise, physiological stressor, and then the whole myocardium goes into something like a program apoptosis. There is a wavefront of necrosis, which leads to a sudden massive amount of necrosis. So this is a hypothesis called as a double hit hypothesis. And this is true in real life also. You would see that patients with alcoholic cardiomyopathies, patient with peripartum cardiomyopathy have in a case control studies, or it has shown that they have higher incidence of truncated titin mutation than the general population. But that means they already are carrying a gene which is already making the myocardium probably vulnerable, and then they get an environmental stress, and then they suddenly develop a myocardial necrosis, myocardial apoptosis, and then fibrosis, and leading to dilated cardiomyopathy. So this patient's gene was this particular patient's gene was titin truncated mutation, and then he had a so probably he was already carrying the titin gene. We screened his family. His other brother is also now showing the signs of dilated cardiomyopathy. And this was his heart when it was explanted during the heart transplant. And you can see that it was absolutely a baggy heart with a lot of fibrosis. Anyway, this brings me to the question that whether should we be doing the genotyping for all the patients? It's not really required. Some of the clues are there. One is that if you have a skeletal myopathy, family history of dilated cardiomyopathy, very low voltages on ECG, you should not have hypertension or LBBB. As the number of points go on increasing, the yield of genetic testing goes on increasing. This is, of course, the monogenetic disorder if you are having it. There is certain a few other things, that if you have a very ring-like LG, the chances of having a genetic cardiomyopathy also increases. Now, this is a large study of more than 800 patients from UK, where they looked at the non-ischemic DCMs and the LG patterns. And what they found that as the percentage of LG goes on increasing, even at much lower percentage of LG, already the hazards ratio for sudden cardiac death and all-cause mortality increases. For the further increase in the LG, the curve almost plateaus. So actually, it turns out to be whether you have an LG or you don't have an LG. That is what it is. If you don't have LG in a dilated cardiomyopathy, your prognosis is quite good. And certain patterns like subepicardial on the free wall, mid-myocardial in the septum are associated with higher incidences of sudden cardiac death and all-cause mortality. And this is another study from the Spanish group where they looked at the non-ischemic DCM, and what they find is this, that in this particular group, 38% patients were gene positive and 26% patients had an LG positive. And generally, these subepicardial ones or the subepicardial with mid-myocardial ring-like enhancements are more common with the desmoplakins, filamin C, and lamin A. So this is another indicator that if you get a very ring-like enhancement, your genetic yield can be almost 50% in picking up one of these genes. And why do we need that? Because currently we have got a lot of literature and evidence to show that certain genes have much more malignant course, unlike titin, which are that way quite the patient has got a very long undulating course. However, some of these genes are more arrhythmogenic, or they may have much more uh, fibrosis and arrhythmic events and heart failure hospitalizations. And these are the lamin, filamin C, transmembrane protein, phospholambin, desmoplakin, and RBM20. If you add to them the presence of LGE and the ejection fraction and the Holters and family history, you can have much better granular risk stratification of patients with non-ischemic DCM. Because as we know that putting a primary prevention ICD in a non-ischemic DCM is a very controversial topic. That is because we are going just by an ejection fraction cutoff, but you can now make it much more granular appreciation of the risk by looking at the genotype, looking at the LG on the MRI and the proper ejection fractions, and then the Holters and family histories and so on and so forth. So I think probably I think I'll have some time for more case. So we'll look at this 32-year-old male. I think this is a very run-of-the-mill case, but I just want to show certain important features in hypertrophic cardiomyopathy. So here is a asymptomatic patient, no family history of sudden cardiac death or unexplained syncope. Now, these two are the most important historical pointers which are important in risk stratification in hypertrophic cardiomyopathy, because the ones which are there hierarchically important risk predictors do come only from the history, the family history and history of unexplained syncope. So the other three come from the imaging, and that is what I want to show you. Now, this is a typical ECG of hypertrophic cardiomyopathy. As you can see, the STT changes and LVH. And as you can see that there is a asymmetric septal hypertrophy and a dynamic LVOTO. So the maximal wall thickness anywhere in the left ventricle, 30 millimeters and more, is in one of the important imaging risk factor, or you can say a biomarker for a high risk of sudden cardiac death. Now, this focal wall thickness can be anywhere. It need not have to be only in the septum. So that is why taking a good tomographic section is very important, and and many times it is much better appreciated on the MRI. Many patients with apical ACM, you can very easily miss an apical aneurysm. And why it is important? Because a lower EF than 50% and apical aneurysm are the fourth and fifth hierarchically important risk predictors in hypertrophic cardiomyopathy. So looking for the apical HCM, many times the apex goes into the apical clutter and you may not pick it up well. So use ultrasound enhancing agents or the contrast, and you will be able to pick up these small apical aneurysms, especially in the patients whom you are longitudinally following for apical hypertrophic cardiomyopathy. Obviously, the LVOTO doesn't feature in the in the high risk features, but it definitely is a part of the HCM risk calculator. What is more important is it is that it has got a prognostic, and more than prognostic, the treatment importance. So if you get a SAM, but the gradient is less than 30, always do a Valsava and you will find a jump. Or you can ask the patient to have a very sumptuous meal and come back immediately. And many times you will find a great increase in the trans LVOT gradient. Obviously, this is important, and as you know that you need to follow them up if you are putting them on mavacamten by doing Valsalva when you are following them every month. Uh, of course, lower down in the wrist are the Holter, which are the non-sustained, faster, longer, and frequent BPVs. And MRI is very useful, especially when you want to look at the EFs, LV apical aneurysm, and also it gives you the lead gadolinium enhancement percentage. So this is since the MRI gives you a lot of tomographic slices, you can measure the thickness at multiple places much easier. Not only that, it gives you a much better LA volume and the LV volumes and the ejection fractions, and it can obviously can pick up even small apical aneurysms. Of course, for that also you have to be very careful in taking your tomographic planes. These are the late gadolinium enhancements. As you can see, these white areas here, and these are the places where the gadolinium gets retained. That means these are the areas with fibrosis. And now you have got software algorithms to find out the percentage of late gadolinium enhancement. Generally, you take this signal intensity of mean plus sixth standard deviation to pick up the percentage of left gadolinium enhancement. Now, studies have shown that a more than 15% LGE can lead to the higher chances of sudden cardiac death. However, you have to be very cautious the way you are applying these softwares. So anyway, the as we looked at the hierarchically, obviously secondary prevention will always be at the top, but the five ones which we talked about hierarchically are the two of them are historical and three are imaging, like wall thickness, EF, and apical aneurysm. Lower down are the NSVT and LG. However, the HCM calculator doesn't take into account the LGE, neither it takes into account apical aneurysm. Anyway, I think I will go for quickly for the last case, and this is a 43-year-old male and progressive heart failure, and this is his ECG. Now, if I show you that he has a echo like this, where he has got such a significant hypertrophy, you would be tempted to see this ECG and tell, oh, this looks to be an infiltrative cardiomyopathy, because you can look at the limb leads; they are hardly barely 5 millimeter QRS complexes, telling you, and you almost have poor R progression V1 to V2. That definitely we're dealing with some kind of an infiltrative cardiomyopathy. And you can see that there's hardly any base to apex contraction, and that is because and you have very restrictive filling patterns and very poor E primes and A primes here, all below 5 centimeters. And on the GLS map, you have got this typical cherry on top pattern. Patient's serum immunofixation electrophoresis is negative. His MRI shows a significant amount of mass, almost 162 grams there, and a very low GLS, as you can see, just 7%. And this is the place where you can see the T1 values before giving gadolinium, after giving gadolinium. So before giving gadolinium, it's a very high T1 values in 1500, which is too high. After giving gadolinium, you can find out the extracellular volume, and that is 70%. Now, normal heart has got an extracellular volume 20 to 25%. So 70% is too high. So this tells you that there is a deposition, there is an infiltration. As you can look at this particular map, very high T1 values and very high extracellular volume, it's only amyloid which sits there. This is a typical gadolinium kinetics, which is called as the nulling pattern, and you may not have to go into the details of it, but generally what happens is with this sequence, generally the LV blood volume nulls first, but here you can see the myocardium is nulling first and then the blood becomes black. And why this happens is because there is too much of gadolinium inside the myocardium, because these amyloid fibrils are very have a great affinity towards gadolinium, and the concentration of the gadolinium is very high, and that leads to this kind of LG images where the LV cavity looks quite black and there is a lot of gadolinium in the myocardium. Generally, these patients, when their serum and urine protein immunofixation electrophoresis is negative and the free light chain are negative, then the PYP scan can be ordered because it is then 100% specific for ATTR. And you can see that what you do here is that you take the count on the heart and on the contractile lung, and the ratio at 1 hour, if it is more than 1.5, you can see the PYP 1 hour. If it is more than 1.5, it is very specific for ATTR amyloid. And there is another classification by Perugini, where what you do is that you look at the uptake of technetium pyrophosphate in the myocardium. If there is no uptake, it is 0. If it is there but less than the ribs, it is called 1. If it is equal to the rib, it is called 2, and if it is more than the rib, it is 3. So this is almost Perugini grade 3 pyrophosphate scan. So a definite ATTR amyloid. In these patients, then you can do the genotyping. If the ATTR gene positive, then it will be a familial ATTR. If it is not, then it would be like wild type ATTR. There are certain interesting features like this, that if you take the ejection fraction to global longitudinal strain ratio in these patients, it is very, very high. It is more than 4.5. Generally, the ratio should be 3 because your EF is 60 and GLS is 20. But here what happens is that the GLS falls precipitously. So anything going up from 4.5, you should think of amyloid. Then there is another interesting is to look at the mass to GLS ratio. Now, most of the time, mass to GLS ratio is less than 5. In these patients, especially if they are ATTR, their ratio is almost goes about 10, while in those AL amyloids, it is generally in the range of 5 to 10. So these are some of the indicators to look for it. Okay, I think with the interest of the time, I think I will stop it here and I will take any questions.
Thank you, Nitin sir, for that wonderful presentation. Now, if I have permission of all the examiners and Mahajan sir, can we proceed to the case presentation on aortoarteritis?
Yes, yes, we can go ahead with the case presentation. And actually, my voice is not good, but this lecture by Dr. Nitin is an excellent lecture, and there are a lot of intricacies you everybody must learn from those things. And the first case, which was eye opener for me also. Thank you. We will go ahead with the case presentation.
Congratulations for the wonderful lecture.
Thank you, sir. Thank you.
Thank you, sir. And I would like to invite Dr. Hitesh Kumar and Dr. Ayushi to start the presentation. Dr. Meena sir will be the internal examiner, and Dr. Mahajan sir, Dr. Sanjay Tyagi sir, Dr. Nitin Burkule sir, and Dr. Ranjan Kumar Sharma sir will be the external examiners.
Today is very interesting thing. Dr. Tyagi sir is a world authority on this particular subject, and he is one of the examiners. So there is a lot of learning for all of us in this case.
Yeah, definitely.
Thank you, sir. Shall I start?
Yes, please start.
Good evening, everyone. I'm Dr. Ayushi, DM Cardiology resident in SMS Jaipur.
Good evening, everyone. I am Dr. Hitesh Kumar. I am also a DM cardiology resident in SMS Jaipur.
We'll be presenting a case of a 12-year-old girl from Ganganagar, Rajasthan, who presented to us 4 days back with a chief complaint of pain abdomen since 9 months, right arm pain while exerting since last 7 months, shortness of breath since last 4 months, and one episode of loss of consciousness 3 months back. So patient was apparently well 9 months back when she developed pain in abdomen, which was insidious in onset, dull aching in character, diffuse and associated with food intake, not associated with food intake. Pain was relieved with over-the-counter medication but recurred soon after. Pain was not associated with nausea, vomiting, or decrease in appetite. Since last 7 months, patient also complained of right upper limb pain while playing, which occurs sometimes after exertion and relieved with rest. And there was no postural variation, and it was not associated with any dizziness. On
Aishu,
taking
can you
further
make
history,
it full present here? Okay.
On taking further history, it was found that the patient also started having shortness of breath 4 months back, which was insidious in onset and gradually progressive, such that initially she developed shortness of breath on playing for around 2 to 3 hours, which gradually progressed to, and she was not able to climb even one flight of stairs. 10 days back, she also had worsening of shortness of breath and she became breathless immediately after lying down, and she was rushed to a local hospital where she was treated with IV medication. 3 months back, she had an episode of loss of consciousness lasting for around 1 minute while she was getting a haircut after a cloth was tied around her neck. It was not associated with any abnormal limb movements and aura. There was no history of any limb weakness, no history of jaundice, no history of blood in sputum and melena, no history of fever or recurrent infection, no history of any abnormal body movements, headache, visual disturbance, no history of joint swelling, rash, and joint stiffness. There was no history of weight loss, bluish discoloration, and blood loss. There was no history of any seasonal variation in symptoms, no history of oliguria or hematuria, and there was no history of chest pain. There was no significant past history or family history, and patient has not achieved menarche yet. Patient is also fully vaccinated, appropriate for age. So to summarize, a 12-year-old girl presented with a history of abdominal pain since last 9 months, right upper limb claudication since last 7 months, shortness of breath which was gradually progressive since last 4 months, with history of orthopnea 10 days back and one episode of loss of consciousness 3 months back, lasting for around 1 minute. So based on this history, we have made three differentials. First was anemia, second was systemic vasculitis, and third, a very unlikely diagnosis was tuberculosis, just because the prevalence of the disease is very high. So should I continue?
So
Yes.
your
So on
symptom
gender
of
physical,
pain abdomen, how do you explain? What is the interpretation?
sir, if we think that the probable diagnosis is anemia, it can be because of some gastric ulcer, but it is not likely because there was no association with food. But in case of systemic vasculitis, it can be a constitutional symptom or can be because of involvement of mesenteric vessels.
The mesenteric vessel involvement, the patient would have pain after taking food. You have said that there is nothing to, no relation with food.
Yes, sir.
Yeah.
We are, if we take all the symptoms in account, the most likely diagnosis is anemia or vasculitis only, sir. That's why we have kept it.
And the anemia will explain your claudication of the right upper limb.
Sir, it might not have been claudication, just a symptom of just pain or a symptom of fatigue that the patient was experiencing. It is
And
hard to
how do you
determine.
explain this loss of consciousness?
Sir, it could have been just a matlab, incidental thing
It's
that
not
would
an
have that
incident.
happened.
The patient was just a collar was some cloth was put around the neck. So what are the
Sir,
possibilities?
sir, we have kept anemia as the first diagnosis just
Why?
because of its prevalence and
Age.
Can it be carotid
because of
sinus?
the age.
Can it be carotid sinus hypersensitivity?
Sir, it could have been, but that would not explain other symptoms. So the only diagnosis among the three that explains all the symptoms is systemic vasculitis, sir.
Involving
Involving, sir, matlab large vessel vasculitis like Takayasu.
any other comments for the
See,
next? Yeah.
the patient is only 12 years old,
Yes, sir.
presented with a right upper limb claudication and dyspnea, orthopnea 10 days back, and one episode of loss of consciousness. So, can it be a case of Schoen complex, coarctation complex, anything which is related to the coarctation?
Yes, sir, it could have been because of coarctation, sir. It could explain claudication and shortness of breath.
But this patient has a rapid progression.
Where?
This patient had
Yes,
rapid
sir.
But in,
symptoms.
sorry. Yeah.
Seek to- It is
Mm.
you understand, Ayushi?
Yes, sir. Yes, sir.
Rapid progression of symptom within last 9 months, and coarctation is a congenital disease starting from early infancy, and the most common feature of coarctation is heart failure in early childhood.
Failure.
Not at this age, presenting and with such rapid progression of symptoms, uh,
Mm.
with upper limb, particularly single arm claudication or developing shortness of breath at 12 years of age.
Yes, sir.
Understood?
Yes, sir.
The newborns or young children, infants can have heart failure because of the coarctation of aorta. But at this age, it is uncommon to have coarctation of aorta with these types of symptoms.
Yes, sir.
Could it be
Yeah.
simple myocarditis?
Yeah.
Sir, the claudication couldn't be explained with that.
Claudication of one limb.
Claudication of, yes, a single limb, particularly.
Shortness of breath, progressive, last 4 months, then became orthopneic, and one episode of loss of consciousness. Loss of consciousness, orthopnea, these are very important symptoms.
Yes, sir.
These are very important symptoms and to be taken. Okay, I think in the interest of time, we may progress.
Yeah.
Things to be discussed. Yes, please.
So on general physical examination, patient was conscious, oriented to time, place, and person, average built with a BMI of 19.8 with normal upper segment to lower segment ratio, and there was no palar, icterus, cyanosis, clubbing, edema, and lymphadenopathy. Spine and back were normal, and patient was afebrile. On vital parameter taking, her blood pressure was 140 over 50 mm of Hg in left arm in sitting position and 180 in both lower limb. The right arm blood pressure could not be taken because there was no pulse. Respiration was 18 breath per minute, thoracoabdominal type, regular with no use of accessory muscle of respiration. JVP was 3 centimeter above sternal angle and negative abdominal jugular reflex. Saturation was 99% on room air and temperature was 98 Fahrenheit at 12 p.m. Her pulse was 84 per minute, regular, high volume, water hammer character, felt in the left radial artery. Her brachial and radial pulsation on the right arm was absent. All other pulses were present. On systemic
Any
examination,
any evidence of any tenderness over left carotid
no, sir,
tenderness?
there was no tenderness over, sir, carotid, sir.
Okay.
On systemic examination, her chest was bilaterally symmetrical with no deformity. There was visible pulsation seen in the neck, suprasternal notch, and in apex, and apex impulse seen in the left fifth intercostal space close to mid-clavicular line. No spine deformity, scar, and sinuses were present. On palpation, the findings of inspection was confirmed. Trachea was midline. Apex beat was felt in the left fifth intercostal space at the mid-clavicular line, hyperdynamic in character. There was no parasternal heave. Bilateral chest movements were symmetrical. There was no tenderness, no tactile fremitus, no subcutaneous edema, and there was no rib crowding and intercostal widening. On percussion, there was bilateral equal resonance in both lung fields. Liver dullness was present in the right fifth intercostal space and gastric tympani on the left side. There was no dullness in the left fifth second intercostal space. On auscultation, S1 was soft, S2 was normal split, S3 and S4 was not heard. A high-pitched, soft-blowing early diastolic decrescendo murmur extending in more than half of diastole of grade 3 by 4 intensity was heard in the left third intercostal space, best heard in sitting up and leaning forward position with the diaphragm of stethoscope at the end of expiration and the murmur increase on passive leg raising and isometric hand grip. An ejection systolic murmur of grade 3 by 6 was heard in the left second intercostal space with the diaphragm of stethoscope, best heard at the end of expiration with sitting up and leaning forward position, with no variation with maneuvers. Another soft low pitch rumbling mid diastolic murmur of grade 2 by 4 intensity was heard at the apex with the bell of stethoscope, best heard in the left lateral decubitus position at the end of expiration, likely to be a Austin Flint murmur, and a bruit was heard over bilateral femoral artery. Peripheral signs for AR were checked, and out of all, Durosier sign, Trobis sign, Hill sign, Waterhammer pulse, Lincoln sign, Corrigan sign, Landolfi sign, and Quincke sign were present. Other systemic examination, respiratory and CNS system examination was performed and it was within normal limits. So moving on to the investigation, Dr. Hitesh will continue from now.
So, sir, on investigation, we found that her hemoglobin is 11 gram per deciliter, and her ESR is 100 mm per hour, which was decreased up to 68 on during the course of the therapy. Her CRP level was also raised, which is decreased over the course of the therapy. Her ANA by IFA and sputum for AFB was negative. So this is the 12 lead standard ECG, which is showing the normal sinus rhythm with normal axis and a volume overloaded type LVH morphology. We also found that on her chest X-ray there is a 50% cardiothoracic ratio, which is suggestive of mild cardiomegaly. There is also pruning of the vessel in the her chest X-ray. There is also sphealization of vessels on chest X-ray, which is suggestive of pulmonary edema and
Great.
pulmonary venous hypertension. Her sputum for microscopy is also negative. We also performed the CT right upper limb angiogram, and we found that there is a complete occlusion in the right subclavian artery up to the axillary artery, and there is proximally there is dilation of the right brachiocephalic artery. So this is complete blockage of the right subclavian and axillary artery. Also, we can see here this is the complete non-opacification of the right subclavian and the axillary artery. Similarly, we see there this is the complete non-opacification of the right subclavian and axillary artery. We also perform HRCT chest and CT pulmonary angiogram to look for the lung involvement, and CTPA to look for the pulmonary involvement, but there was no pulmonary involvement in this case. On 2D echogram, 2D echo, we see that. So in 2D echo, in parasternal long axis view, we can see there is a dilated left atrium and left ventricle. Along with that, there is severe AR, severe aortic regurgitation with vena contracta of 6.4 millimeter. On parasternal short axis view, we can found that there is a mild global hypokinesia of left ventricle, and there is we can see in suprasternal view there is arch of aorta and its vessel, and we can rule out the arch of aorta, coarctation of aorta from this view. In carotid artery Doppler, we found that in right subclavian, right carotid artery, there is a diffuse thickening up to 2 millimeter in the right carotid artery. So our final diagnosis is systemic large vessel vasculitis, Takayasu arteritis, active disease. ITAS 2010 score is 15. Takayasu arteritis associated cardiomyopathy with severe valvular aortic regurgitation, with severe pulmonary venous hypertension, with no signs of pulmonary arterial hypertension, with moderate LV systolic dysfunction, with no evidence of congestive cardiac failure and infective endocarditis or anemia. Patient is in normal sinus rhythm with the functional NYHA class 2. Thank you, sir.
So your symptom of shortness of breath, orthopnea, can it be explained by your clinical examination of heart? You have a normal size heart. You don't have any third sound. You don't have any cardiomegaly, at least on clinical examination.
Sir, when the patient came to us, her failure has already improved. She went to a local hospital before coming to SMS.
Achha.
So that could have been the reason why we couldn't have a S3 and symptoms of acute heart failure.
What was the reason for soft S1?
Another thing that I want to ask Dr. Ayushi.
Yes,
At
sir.
this age of 12 years, is the S3 a sign of heart failure? Dr. Ayushi? Hitesh?
Yes.
You want to answer? S3 in a young child or young person is a sign of heart failure. What are the causes of heart
It
failure?
is not a hard sign as such,
So it can be
but with
physiological
the
finding in the young child.
but
It
with
can.
the with the symptoms and all other examination finding, it could be relevant.
Yes. So one cannot only depend on
Yes, sir. On one of the signs.
yes. But the history is very important. Like you said, the history, rapidly progressive history is very important.
Yes, sir.
And what does the rapidly progressive history explain? What does it suggest to you?
Sir, the activity of the disease is very high, sir.
Yes, the
If
No,
we think that this is Takayasu.
patient.
Also, sir, the symptom progression in the sequence that it did is also highly suggestive of the sequence in which Takayasu occurs.
It's not only go for but for Takashu, this is an active stage of disease.
Active stage, yes, sir.
Stage of disease,
you
rapidly progressive symptoms, and
नहीं है फंक्शन नॉर्मल है दोनों.
you have a combination of all hypertension, volume overload, and myocarditis. These three combinations made the patients very worse.
yes.
Yes, sir.
What is
हाँ
differential diagnosis?
Sorry, sir.
अभी फंक्शन EF 60% है, हर जगह 60% कर दो. जी
40% blood.
जी.
Sir,
Yeah.
her ejection fraction was a little on the lower side, 40%. Her
40.
ejection fraction was 40%.
Despite being an aortic regurgitation,
Yes, sir.
it is quite severe dysfunction for a patient of
Yes.
aortic regurgitation. Patient of aortic regurgitation should have the
A
ejection.
higher ejection fraction. Yes, sir.
So even if it is 40%, it is quite high.
Yes, sir.
So only. So what are your finding? What are your clinical criteria to suggest that this is Takashu arthritis? What are the current criteria? I would say that what are the current latest criteria for diagnosis of Takashu arthritis?
Sir, if we go by the modified Ishikawa criteria, we have fulfilled one of the major criteria, which is subclavian artery stenosis, right subclavian artery stenosis, and two of the minor criteria, which is aortic regurgitation and high ESR at presentation.
What are the latest criteria for diagnosis of Takashu arthritis? Latest criteria. Ishikawa is quite old.
Sir, modified Ishikawa, Sharma et
Sharma.
al. Modification of the Ishikawa.
What is the latest criteria for diagnosis of Takashu arthritis?
ACR criteria.
Yes.
Sir, is
ACR criteria. Which year? They were earlier ACR criteria, now the new ACR criteria. Which year? New ACR criteria. And what are these? What are the latest criteria for diagnosis of Takashu arthritis? Because then only you can, because these are important. Okay. That you should read that. That what are the latest criteria for the diagnosis of Takashu arthritis? Write it down and read it. So what are the large vessel vasculitis that you know of?
So, giant cell arteritis and Takayasu arteritis.
How do you differentiate giant cell arteritis from Takashu arteritis?
Sir, age, according to age, we can differentiate. Giant cell arteritis mostly occurred in elderly male patient, while the Takayasu arteritis mostly present in younger age group and in female population.
Young age, females, more commonly females. That
Yes.
one thing. What are other features? What
Sir,
are the
Takayasu arteritis presented as a pulseless disease with blood pressure differences, while giant cell arteritis presented as pain, jaw claudication, pain while chewing, jaw claudication, sir, temporal lobe pain.
can the giant cell arteritis have arch vessel involvement?
Yes, sir. Arch
Yes.
vessel involvement can be present, only large vessel involvement can be present, but subclavian involvement specifically is more common in Takayasu,
Yes.
while carotid involvements and is more common in JCA.
What is usually not seen in giant cell arteritis, which is seen in Takashu's? It is the abdominal aorta involvement is commonly seen in Takashu arteritis, but not in
And
arteritis.
and pulmonary, sir.
Yes.
Abdominal aorta and pulmonary.
No, is uncommon presentation, but the abdominal aorta involvement is very common, particularly in India. India has very commonly abdominal aorta involvement as compared to the other parts like Japan and China and Korean. Indian Takashu arteritis have more commonly abdominal aorta involvement. So it is a major differentiating feature from giant cell arteritis. Abdominal aorta and abdominal aortic vessels involvement.
Yes.
is less common in giant cell and more common in Takashio's arthritis. That is another feature. What are the other criteria? One, you said this temporal artery involvement is more commonly seen in more commonly, but it's almost sine qua non for the giant cell arthritis.
Sir, in ophthalmic involvement, in Takayasu, it is mostly retinopathy, while in GCA, it is optic neuritis.
Yes. And what type of in
Optic.
Takashio, what type of this ophthalmic involvement?
So there are retinopathy.
What type of
With
retinopathy?
What is characteristic?
Sir,
Type
in
of
Takayasu arthritis, sir, there is four stages of retinopathy. Sir, we can see here in this stage. Sir, there are four stages. One in first stage, there is uh, unusual dilation of the artery and vessels, and later on they joins and form a AV malformation.
Yes, what like four stages, no?
Yes, sir. Fourth
Most
stage.
commonly, what you should shade that there could be hypertensive changes or ischemic changes.
Yes,
What you are describing is ischemic type of retinopathy in Takashio arthritis. There could be only a hypertensive type of
so
retinopathy
more,
in Takashio arthritis also, when patient being severely hypertensive and having development. But these four stages are commonly in ischemic retinopathy.
ischemic, yes, sir.
Yes,
That is the more common presentation than the hypertensive retinopathy.
yes, hypertension in our part of the world is quite common, but the ischemic type of involvement is also very severe. But it is not used for different. Like he said, the arthritis of the is seen in more commonly in giant cell arthritis. What else? What are the new in the new criteria? Previously the criteria said that less than 40 years Takayasu arthritis occurs in less than 40 years of age. Ishikawa's, our Indian criteria, all these criteria mentioned, and the earlier ACR criteria also mentioned less than 40 years of age. But now newer criteria says less than 60 years. But I would say, but 40 years is more specific for Takayasu arthritis and differentiating like more than 50 years or above is giant cell arthritis. But commonly, patient who develop Takayasu arthritis early age can present at a later age also. But your patient is typically developing in early young age, female, developing severe symptoms. Anything else, Dr. Meena? Dr. Dheeraj?
Are there any blood markers to assess Takayasu arthritis, diagnose Takayasu arthritis? And how do you approach management of Takayasu patient with Takayasu arthritis with obstructive symptoms, however, who have inflammation, evidence of inflammation?
Yes,
Sorry,
that
sir, can you repeat the question? Our connection got lost.
So first question is, what are the blood markers of depicting disease activity in Takayasu arthritis? Second is, in case of patients with disease activity, how do you approach managing such patients?
Sir,
Sir, the blood markers are CRP, ESR, and there is a new blood marker that is pentraxin 3, that is vascular CRP, that is long pentraxin. That is secreted from all type of blood cells, and uh, for evaluation of the disease, we used to study the
ESR and CRP.
ESR, CRP along with clinical feature. But now we also look for the imaging feature to assess the disease severity.
Yes. Activity also.
And how do you manage it? If there is a patient with disease activity, how do you
Sir, in
manage?
case of
What drugs do you
in
use? At
case of
what doses do you use? How long do you use? What do you monitor?
in case of active disease, sir, we start with glucocorticoids with synthetic DMARD, sir. Most commonly we use in India is mycophenolate and azathioprine and methotrexate, sir. So after giving it for 2 to 3 months, we start with usually 40 to 60 mg per day of glucocorticoids and taper it to around 20 to 30 milligram per day in 2 to 3 weeks, and then continue to less than 10 milligram per day. And if in 3 months there is non-resolution of disease, there is no decrease in disease activity, then we can either increase the dose of glucocorticoids, or we can start biological DMARDs.
What
And
biological
as
DMARD?
a in resistant cases, we can use tocilizumab. We can use TNF alpha inhibitors, infliximab, adalimumab, and tarnacept, or we can go for a JAK kinase inhibitor like tofacitinib. In resistant cases, we can use IL-6 inhibitors like tocilizumab. There are also some studies where biological DMARDs and glucocorticoids were started in the initial phase only, rather than waiting for some disease resolution.
Tyagi sir, you are muted.
Dr. Ayushi, nowadays the treatment that has been advised for treatment of these patients with active stage of disease, that from initially itself, not only
Yes, sir.
corticosteroid, start with them immunosuppressor also together, like
Yes,
methotrexate,
sir.
cyclophosphamide, or
Synthetic DMARDs and glucocorticoids. Yes, sir.
mycophenolate. And then after around 3 months, you can gradually withdraw your steroids and continue with the methotrexate. So you have
Yes,
to
sir.
fast and effectively from the initial stage, not wait for the ESR not to subside to start methotrexate. Start the
Yes,
combination therapy for these Takashwate nowadays. For resistant cases, you have rightly said that you start the other like tocilizumab and infliximab type of drugs. What are the problems
yes,
with
sir.
newer drugs that are being started, the tocilizumab and infliximab? What are the problems with these drugs, or what are the what is the effect of these drugs?
So there is more risk of infection, and also it was noted that there were more relapses with these drugs.
Yes,
Even the remission rate was higher, but the relapse rate was also higher with these drugs.
yes, correct, correct. Other question of what was asked by Dr. Dheeraj was, how will you treat apart from your immunosuppressive or steroids? What are the other methods of treatment? Dr. Dheeraj is smiling. Yes. What are the other methods?
Invasive, sir, when the patient is not in active state, we can perform invasive therapy. Interventional therapy can be performed.
First of all, you have to do imaging of these patients. Imaging is very important. You have done echocardiography. Now you are your CT angiogram shows that there are multiple blockages, particularly in the arch arteries. There are multiple blockages. The left subclavian, the innominate, carotid. How are the innominate and carotids? The right carotid, right subclavian is totally occluded. What are the other involvement? Carotid, subvertebral, sub, left subclavian is, how is
So
the left?
the imaging we did not show any occlusion, but maybe the imaging was not done correctly. So we
No,
are planning to do it again.
no, imaging is done correctly. You see, you are not able to feel the pulse on the right side, and the
Yeah.
subclavian axillary artery is almost totally occluded. Only there are few plateaus. So
So for the carotids, we could.
carotids, could you feel the carotids?
Yes, sir.
Yes, sir.
Bilateral carotid were
Any bruit over-
palpable, and sir also.
No, no. I am asking any bruit over the carotids.
No, sir, there
No,
was
sir.
no bruise, sir.
And we
Okay.
also performed sir carotid Doppler, which was also.
So there was thickening of the carotid vessel wall, but there was no signs of obstruction.
There is involvement of the carotids.
Yes, sir.
Any other features or examination specific for Takashus arthritis? What are the other important?
Dynia.
Car-
So carotidynia.
Sir,
Nothing.
there should have been a carotidynia if the vessel was involved.
That is indication. No, that is indication of active stage. Vessel is involved here. The carotid is thickened. But early active stage of disease has carotid artery tenderness or carotidynia, which is an indicator that this is active stage. Recurrence of carotid artery symptoms also, and if like this patient is not having carotid tenderness now, but after 1 year or 2 years, he develops or she develops the carotid tenderness. So that is another sign that patient is having recurrence. In Takotsubo, it is not that recurrence is once, that active stage is once. It can occur in
Yes, sir.
peaks and troughs later on in the life course.
Yes.
Which arteries are not involved in Takayasu arthritis?
Sir,
Which
coronaries.
relative middle-sized arteries are not involved in Takayasu?
Coronaries are commonly involved in Takayasu arthritis. Don't forget it. Your patient can have
Yes.
about 10 to 15% of patients have coronary artery involvement. What are the percentage of pulmonary artery involvement in India?
20%.
15 to 20%.
In outs no, up till 25%, around 25%, but the figures from the other countries like Mexico shows higher percentage of involvement. So what are the important question that is asked in exam? How do you differentiate the Indian type of Takayasu arthritis from Japanese type of Takayasu arthritis? What are the important features that distinguish these two types, Indian type and the Japanese type? बोलिए बोलिए, आपको आंसर पता है?
Sir, firstly, the female preponderance is less in Indian subcontinent.
India has also female preponderance.
No. Yeah.
Is lesser, sir, in India. It is around 3:1, while in Japan it is much more.
The different series, very different. So don't worry about the female preponderance. What are the other features? See, arch enlargement is more common in Japanese type of Takayasu arthritis, while abdominal aorta and is more
in infrarenal, infradiaphragmatic involvement is more common in Indian
Yes,
scenario.
we also have arch vessel involvement. That is also commonly seen. But like Japanese type have predominantly arch vessel involvement, we have both arch vessel involvement as well as abdominal aorta
Infradiaphragmatic, yes, sir.
in segment. What are the other distinguishing features? See, HLA involvement is differentiate. What is the commonest HLA type that is found in Takayasu arthritis?
Sir, HLA B52.
B52. Yes, very good. Very good. B52 is commonly found in Takayasu arthritis. So the genetic markers are also important in the pathogenesis of Takayasu arthritis. What is the pathogenesis of Takayasu arthritis? What is the cause of Takayasu arthritis? Cause.
Sir, granulomatous, it is a granulomatous disease. So mainly involved T cell, the main pathway involvement is of T cell immunity, but there's also evidence of some involvement of B cell immunity, but mostly it is because of T cell, it is T cell mediated.
T cell mediated.
Involving interleukins.
If I ask this question, the important thing is immune mediated vasculitis. It is immune mediated vasculitis. That is the first thing that you should.
Yes.
These are important. That immune mediated vasculitis affecting the large vessels.
Yes.
So why this patient had this syncope? This patient had abdominal aorta involvement, the abdomen pain, syncope. How do you explain those symptoms?
So subclavian still syndrome can be explanation for this. Like her subclavian artery is blocked and the blood from the vertebral artery goes to the other side. So while the a knot was tied around her neck, so the vertebral artery has been blocked. So there was a decreased.
I said that it could be hypersensitive carotid sinus. That was very important. Like the patient was tied with the clot and then the patient had this type of symptom. So these patients can also have hypersensitive carotid sinus apart from obstructive feature, because obstructive feature will continue long term unless you relieve.
Yes,
but patient had one episode of this symptom. So your history is also very important.
This subclavian still will occur only if your stenosis is very proximal to subvertebral.
Yes.
It's now beyond the vertebral also. So it will not steal from the vertebral.
Yes.
So this.
What are the investigation besides your echo and CT that you should do in the patient with Takayasu arthritis? If you have facilities, what are the other investigations? Like one was ESR, CRP was a marker of inflammation. How can you detect inflammation in Takayasu arthritis? What ways to detect inflammation?
Sir, MR angiogram can be done to look for the disease activity. We can look for the
outer thickness.
aortic
Thickness
thickness.
of outer around 3.12 was selected as a marker of
Marker.
disease activity.
Yes. And
Thickness of
else the PET
Sir,
CT.
PET scan can be done. Yes, sir.
PET
PET
CT.
scan. Yes.
PET CT will
Yes, sir.
show you which part of aorta, which arteries are involved, which are having active inflammation. So after relief of active inflammation, then your medicines are effective or not. These can also be assessed by PET CT very effectively. This is a very important investigation, though it is not commonly available, but it is an
Yes,
important.
sir.
What are the other markers besides ESR and CRP for the activity?
Pentaxin 3.
Pentaxin 3, yes. And interleukin levels also. And Pentaxin 3 is the. So, what are the other modes of treatment? Dr. Dheeraj was asking you. You have not told still.
Sir,
But
apart
what
from
else?
immunosuppressive therapy,
Yes.
But in this
if
patient,
we can,
especially, you have to look for the other. What are the other drugs which are needed in this patient?
sir, we have to give heart failure management also.
That's right. So we will not discuss it at all. She presented with the acute decompensated heart failure, which is now. She's got severe
Yes,
AR
sir.
LV dysfunction, so that has to be managed apart from the disease itself.
Apart from the disease, yes, sir.
Any involvement of the abdominal aorta in this patient?
No, sir.
No, sir.
CT
Sir, we have
CT does not show
no, did not.
any
No, sir. There is no. No,
So,
sir.
so what is the cause of aortic regurgitation in this patient?
So aortic root involvement, sir. Aortic arch and aortic root involvement, sir.
Dilatation of aortic arch and aortic root dilatation is
Aortic
common. What are the valvular involvements in Takashima valves? What are involved? One is commonly involved is aortic valve, aortic regurgitation is common. What others? Mitral regurgitation is also common. But most commonly is aortic regurgitation.
Commonly is aortic regurgitation. Yes, sir.
Yes. Anything else? I think. What is the time now? Going to close.
Dr. Dheeraj says, what are the role of intervention? I think that's what
Sir,
Dr. Dheeraj
in
was asking about.
adults,
Yeah.
No, not only in adults,
it is.
also in children.
Sir, in adults, it is quite common to perform endovascular repairs. In children, it is less commonly done, but
No,
it is an option.
this is not correct. Whenever there is severe ischemic symptom of any organ, severe ischemic symptom of any organ, whether it is the carotid artery, subclavian artery causing claudication, or renal artery causing hypertension, aorta involvement causing hypertension, as well as claudication of the lower limbs, then also one should perform as earliest. This is not children versus adults. If the children are having severe stenosis, then they also need it as a urgent treatment. It is a life-saving type of treatment for these children. In fact, you should know that renal artery stenosis is the commonest cause of renovascular hypertension in children in India.
Yeah.
Your books will be mentioning fibromuscular dysplasia, but in our country, the commonest cause of renal artery children is Takashima arthritis. So, if there is patient is having severe hypertension, another common presentation is heart failure. Hypertension with heart failure. So, they also are commonly associated with stenosis of the thoracic aorta or renal arteries. So, they need early and urgent interventions to relieve their ischemic symptoms, whether renal arteries or the brain arteries or arch arteries, anywhere else in the body. Apart from stenosis, what is the other manifestation of Takashima arthritis? Simple. I have told you.
Constitutional symptoms.
No, aneurysms he's asking.
Aortic aneurysms.
Aortic
Are also. How common are the aortic aneurysms?
Yeah, sir. 18 to 20%, sir.
If you say 10% for every question, then also you'll be correct. Like involvement of 10 to 15% of this thing. Then similarly, the mitral regurgitation is also around 10% involvement. That some pulmonary artery involvement also you said around 15 to 20%. So for India, this is also quite easily to remember. You will not be wrong. Too large. Commonly, 80% or 80 to 90% are stenotic lesions, but about 10 to 15% are aneurysmal lesions. Patient can have both type of lesions. Patient can also have stenosis as well as aneurysms in the same patient. Okay. Good presentation, good case. How will you manage this
Thank you,
patient?
sir.
How will you manage this patient now?
Sir, we have taken rheumatological consultation also, and they have started the patient on pulse therapy of glucocorticoid along with methotrexate for
Yes.
now. And we have, from our side, we have started her on heart failure management and IV diuretics, sir.
Good, good.
So,
And plan for early intervention for the subclavian artery if it is possible based on the angiography.
yes.
Commonly, we usually do angioplasty when there is activity has subsided. But in patient with severe symptoms or severe ischemic symptoms like 99% stenosis or 90% stenosis causing severe ischemia, we may have to do angioplasty even in the active stage of the disease. Okay?
But
Yes,
stents
sir.
are avoided.
Yes, sir. Stents are avoided.
Yes.
What happens to Takayasu arthritis in pregnancy? Does it get flared up? Does it go under remission? Does it remain the same?
Sir, because there is involvement of both type of immunity, it can remain same or it can flare up also. But the main problem is with the drugs that we have to give a female
Yes.
in case of pregnancy.
That
We
is,
have only very limited drugs that can be given.
yes. Depending on the stage, whether it is an active stage of disease or chronic stage of disease. If the patient has gone into chronic stage of disease, ESR, CRP, normal, patient having pregnancy, then it depends whether with which arteries are involved, whether stenosis of the renal arteries or abdominal aorta or whatever arteries are involved. It is depend. The pregnancy has higher risk in patient with Takayasu arthritis, but it can be managed. That is what mostly patients are severely hypertensive, and you have to do management of their severe hypertension. And some patients are also having heart failure.
And the issue with Takayasu arthritis is if bilateral subclavians are involved, you will not be able to detect the blood pressure.
Very
So,
important. In emergency, sometimes patient comes to you with you are not able to get blood pressure in both the arms and start the patient on the vaso. In fact, the patient may be hypertensive. A very important point has been brought out by Dr. Dheeraj. So it is should be remembered.
Yes.
Yes, sir.
Yes. Very good presentation. I think congratulate Dr. Meena and their residents for their beautiful presentation and discussion.
Thank you, sir.
Yeah, thank you, sir. There is one question in the chat. I think somebody asked, summarize the heart failure management for severe aortic regurgitation. So can you highlight upon this, Ayush?
Sir, we'll start the patient on IV diuretics along with the enalapril for this patient specifically, along with the beta blocker and MRAs.
Okay, what is the role of newer anti the GDMT? What are the drugs, especially in children? Like, what is the
So there is
role of army? I think that must be the that's why they must ask the question. What is the role of ARNI and the SGLT2 inhibitors in heart failure in children?
so there is very limited role of ARNI specifically in heart failure due to autoimmune disorders. They were excluded from the studies. So there is very limited data available for ARNIs.
Good answer. Most
Yeah.
they don't have Takayasu arthritis to include in their series.
they did have pediatric dilated cardiomyopathies. There was a paper that was published for children between 12 to 18.
18, yeah.
Their ARNI was definitely effective. But as you rightly said, Takayasu arthritis has not been adequately studied.
But like the heart failure itself, at most of these types of drugs, which are the four pillars of heart failure therapy, are effective in this, but we don't have any studies to support.
Evidence.
Yeah.
So, sir, thank you very much. I think we thank the Ajanta Pharma for this bringing out this DM cardiology training program from the part of Cardiological Society also. I thank Ajanta Pharma for this important initiative, and Dr. Sharma and Dr. Dheeraj and Dr. Ajay Mahajan also for this important initiative.
Thank you.
Me also for bringing out these students.
Thank you. Thank you, sir, for giving us the opportunity. And I think the good job from Ritesh and Ayushi. So congratulate and keep it up.
Thank you, sir.
Thank you. Good night.
Thank you, sir.
Night.
Yeah, sir. So may I go with a formal vote of thanks now?
Yes.
Yes.
So very good evening to all respected doctors. Once again, on behalf of entire Ajanta Pharma, I am Sunny Jaiswal, AGM Marketing, taking this opportunity to place a formal vote of thanks on record for making our fifth edition of DMPG Master Workshop a grand success. Our heartfelt thanks to all esteemed panel members and participating PGs for the presence and the active involvement as such. We'd like to specially thank our today's PG speaker, Dr. Ayushi and Dr. Hitesh Kumar, for the insightful presentation also. We also extend our sincere thanks to expert speaker Dr. Nitin Burkule sir for his enriching and thought-provoking session. Would like to acknowledge the valuable contribution of our today's expert panelists Dr. C.B. Meena sir, Dr. Sanjay Tyagi sir, and Dr. Ranjay Kumar Sharma sir. Special thanks to our course director Dr. Ajay Mahajan sir and Dr. Dheeraj Kumar sir for the continuous guidance, encouragement, and support in shaping up this academic platform as such. Once again, a big thank to all the DM and DNV participants for investing your valuable time in learning from all these stalwarts of cardiology. We highly encourage you to continue your active participation in forthcoming 3 more academic sessions which are pending now. Also, please don't forget to log in for our 6th edition of the program, which will be there on the next Friday, 21st of November at the same time. And just to reiterate once again, the online quiz will be live now after 5 minutes and will remain open till 12 o'clock tomorrow. So with this, we conclude our today's evening program. Thank you once again, one and all. A very good night and wish you all a very happy weekend ahead. Thank you, one and all. Thank you so much.
Thank you.
Thank you. Thank you, everybody. Thank you, sir. Thank you, Tyagi, sir.